We'll get started with some housekeeping. In order to be more accessible, we have enabled closed captioning for this webinar. Look at the Zoom toolbar to turn on closed captioning in your view. You may need to click the three dots that say More to see the closed captioning option. Okay. Please feel free to share any questions in the chat as we go through the slides. Chapter staff will make sure that the questions are shared with Dr. Fulton during the Q&A. Dr. Fulton has no relevant financial relationships. And without further ado, I'd like to introduce Dr. Kyle Fulton. Dr. Fulton is an associate professor of pediatrics at Louisiana State University Health Science Center and medical director for the craniofacial team at Children's Hospital of New Orleans. He's a fellow of the Louisiana AAP and has presented in the past at our annual conference, the Potpourri. I will now pass control over to Dr. Fulton.
Unmute. All right. Now let's see if I can get this running. And I'm going to swap. All right. So, hey, everybody. I'm Kyle Fulton. I am, like Joey said, I am an associate professor of pediatrics here in New Orleans and work with LSU and also with the Children's Hospital craniofacial team. I have no disclosures or conflicts of interest. And I kind of wanted to start my presentation talking about what is craniofacial pediatrics, because most of the time when I talk to someone new and I tell them what I do, I always get kind of a blank stare and a nod, a reassuring nod, but no one really knows what I do until I explain it. So it's kind of a made-up field of general pediatrics that specializes in the non-surgical, so the medical management of children born with craniofacial conditions or anomalies. I help provide a medical home here at Children's for these complex kids. I stand in the middle of the circle with the patient while all these other docs and team members are helping formulate a plan, and I help make sure that we have a patient-centered, holistic approach to their team with all 12, 15 specialists that they have. And I'm a supplement pediatrician and do not take the place of their primary care pediatrician in the community. Definitely want to work hand in hand with you all to make sure that these kids are getting the best care. The objectives today are to emphasize the importance of multidisciplinary care for children with cleft lip and cleft palate, outline an overall timeline of care for kids with a cleft lip and palate, and to discuss potential interventions by the pediatricians in the communities throughout childhood. And before we start, kind of running through some of the terminology that we're going to use for this lecture, and classifying clefts. We try to do that by anatomy, typically looking at unilateral versus bilateral, then including the anatomy that's involved, the lip, alveolus, or gum line, and then the palate. And whether it's complete or incomplete, meaning complete goes all the way from the front, all the way to the back, or is it incomplete? Does it not go all the way from the lip, all the way to the palate, or does it not go all the way into the nasal cavity if it's a cleft lip? And some of the acronyms or abbreviations that I'll be using: a CPO is cleft palate only, meaning just a cleft palate. CLA is cleft lip and alveolus. CLP, cleft lip and palate, and then BCLP is bilateral cleft lip and palate. Looking at the distribution of clefting in the U.S., and the numbers that we see here at Children's mimic this pretty closely. The most common is unilateral cleft lip and palate, and then the most rare is actually a bilateral cleft lip or alveolus without a cleft palate. And when we look at epidemiology of clefting, children with a cleft lip and palate have a little bit different epidemiology than those with a cleft palate only. So talking about the ones with cleft lip and palate, it's about 1 in 600 to 1 in 1,000 births, depending on what statistics you're looking at and the year. But in general, that's about 4,500 kids a year in the U.S. born with clefting, with a cleft lip and palate. And that does differ based on race, with those of Native American, Native Alaskan, Latino, and Asian descent having highest rates of clefting, and those of African or African American descent having the lowest rates. It is more common in males. It is more commonly left-sided. When talking about cleft lip and palate specifically, about 30% of these kids will have some sort of syndrome, meaning about 70% are isolated or non-syndromic, and basically the only thing going on is their cleft. Up to 33% of kids, depending on the study, will have a family history of clefting, not necessarily a direct or a consistent mode of inheritance, but about a third of the kids will have another family member of some sort, even if it's a cousin, that has a history of a cleft. It is more common in those that are monozygotic twins, so 40 to 60% concordance in monozygotic twins, but those of dizygotic, basically 5% concordance, which is about the same as if it was just a regular sibling. When looking at cleft palate only, it's a little less common than cleft lip and palate. It's about 1 in 1,600 births in the US, and about 2,600 to 2,700 infants a year are born with a cleft palate only. This is more common in females. About half of these kids will be syndromic or have some other things going on. And there are in a couple forms of isolated cleft lip and palate that are autosomal dominant or X-linked. In general, there's over 300 syndromes associated with orofacial clefting. Those can be either a single point mutation. Some of those are chromosomal abnormalities like 22q deletion, trisomy 21, and some of those are teratogens, which we'll talk about in a second. And they're adding new things all the time. About a month and a half ago, a new paper came out written from a group in Philadelphia talking about fentanyl exposure in neonates or prenatally, and how we're seeing infants with a pretty classic group of anomalies when they've got fentanyl exposure in utero. And one of those things is the cleft palate, along with some GU differences. It almost mimics Smith-Lemli-Opitz. So it's a new interesting thing to watch out for in the coming weeks and months to see how that pans out. The little guys with cleft lip and palate that we think are non-syndromic, we typically think of these as a multifactorial condition, meaning it's a combination of genetic and environmental factors. But there are some things that do increase the risk of a baby being born with a cleft lip and palate. One of those is advanced maternal age, maternal obesity. Smoking during pregnancy can double the risk of a cleft lip. Diagnosis of diabetes prior to pregnancy. And the reason that is the cleft forms at 7 to 8 weeks of gestation. And most of the time, things like gestational diabetes don't show up until a little bit later in gestation. So gestational diabetes is not as much linked to clefting as diabetes diagnosed prior to pregnancy. Some of the classic medications that can cause clefting are your antiepileptics, your Topamax, valproate, phenytoin. And folic acid supplement, when it comes to clefting, is controversial. There's tons of evidence showing that it prevents neural tube defects, but when it comes to clefting, every year or so a new paper comes out, one showing it prevents clefting, and then the next year a paper comes out showing it doesn't. So while it may or may not help clefting, the AAP and ACOG recommend that all women of childbearing age do consume 400 micrograms of folic acid daily to prevent spina bifida and anencephaly, which are neurotube defects, and possibly increase or decrease the risk of clefting in children. So why does it matter? What do we need our palate for? There's kind of three things. And the first that we think of is feeding. So in order to feed effectively, we have to be able to form suction. And how we do that is our palate goes to the back of our throat and closes off our nose from the oral cavity, allowing us to form suction and get milk out of the breast or a bottle. So if you have a big hole in your palate or your palate's not moving, you can't form suction as well. It's like trying to drink out of a straw with a big hole in it. So our little guys are going to end up needing special bottles and not going to be able to breastfeed effectively. I'm going to talk quite a bit more about that in all of these in just a minute. The second thing we need our palate for is speech. So to make those pressure consonants of B, D, P, T, K, those kind of hard pressure sounds, again, our palate goes to the back of our throat and closes off sound going through our nose. And so it all comes out of our mouth. And when you've got a cleft palate, there's a hole there, or when you've got palatal insufficiency, you can have velopharyngeal insufficiency. Basically, some of that noise comes out your nose. And so you sound like kind of mushy, you sound hypernasal, but almost kind of like you've got a cold. And my speech therapists, they can all mimic it. It's something I've tried to do, but I cannot get the mimicking of it down. So maybe next time I give this lecture. And then the third thing that's our palate helps with is hearing. And this is always the oddball. The parents always kind of look at me confused when I talk about it. But it's got to do with eustachian tube patency. So in utero, embryologically, we start out flat, our face rolls around, and we have the two lateral prominences coming over that are forming the lateral parts of our palate, our cheeks, and then you've got the maxillary component that's coming down from above that contains the nasal septum, the premaxilla, and the philtrum. And so ideally, when we're formed, the back of our palate, especially the soft palate, the muscles come together and form an arch. And when you are born with a cleft, they don't. They come together and don't form an arch. So when we're swallowing or when we yawn, what we're doing is lowering that arch of palatal muscles, stretching the eustachian tube, allowing for pressure equalization and for fluid to drain. And so if your palate isn't formed correctly and those muscles aren't stretching the eustachian tube, they can end up with negative pressure in the ear, which can lead to fluid buildup, which can lead to ear infections and hearing loss. So children with cleft lip and palate are increased risk of hearing loss. So I'm going to talk about the timeline. I'm going to talk about each part of this a little bit more in depth, but there's a lot of different steps to the timeline of care for kids born with cleft lip and palate. And for every child, they don't necessarily always need every step of this timeline, but it is something that we always want to talk about and make sure that they are kind of staying on a timeline and making sure that we're offering these things if they need it. But the important part for, I think, pediatricians in the community are the potential targets for intervention. So yes, I would love for all the pediatricians in the community to know the general timeline so that when they've got a 5-year-old that hasn't been seen in cleft team for years, you all know the timeline a little bit and know to kind of get them back into care. But I think the bigger parts here are the other interventions. So in those first couple months of life, nutrition and growth are so important. Another thing that you all are really good at, and us at the Children's Hospital who are not seeing these kids as much, may not see as easily, are things like parental bonding and postpartum depression. Moms that have a baby with a cleft lip and palate are at increased risk of having postpartum depression. I think that's with having a preterm baby, having kind of any medically complex child, the risk of postpartum depression is higher. And so I know that in the communities, pediatricians have gotten really good at doing postpartum depression screening in the past few years. And that's something that I have not, but probably should. The other thing, talking about hearing, we check hearing a whole lot, but as well, it's something that you all do at their well visits as well. Speech. Sometimes we're not seeing these kids but once a year, but you're seeing them every few months for a cold or checkups and all the other things. So helping them get into speech therapy when needed, as well as language development, not necessarily just speech, but coaching families into reading to their kids. Reach out and read programs and other things are super important, and you can never emphasize reading to families too much. As well as a lot of issues with schools. So my kids do have increased risk of issues in school. But you all in the community are better at knowing the resources that you have and how to take care of those problems in your community. As well as psychosocial things. So how are the kids getting along with each other, and bullying, and all of those things that are an issue for any child, but can be especially worrisome for some of kids with facial differences. But again, pediatricians in the community tend to have knowledge of the resources available to families. So ideally, my job with a child with a cleft palate starts at a prenatal consult. Typically at the 20-week anatomy ultrasound, one of the recommendations is to do a facial profile view. And looking at the most recent studies, detection of cleft lip ranges from 16 to 93%, depending on a lot of different factors: fetal positioning, maternal body habitus, and ultrasound tech experience. That percentage goes up a whole heck of a lot when we're using 3D ultrasound, up to 82 to 100%, depending on the study. But typically, you can only see a cleft lip on ultrasound. Seeing a cleft palate is pretty difficult because ultrasound doesn't travel through bone very well. And to get to the palate, especially the posterior palate, you have to go through the maxillary bone and be able to see the posterior palate. But the soft palate is made of muscles, as is the tongue. And the tongue and the palate typically sit pretty close together in these little guys. And sometimes if there is a cleft, the tongue is in the palate. So it's pretty rare to see an isolated cleft palate on ultrasound and to get a prenatal diagnosis of cleft palate. But when I see a family and I'm talking about a prenatal consult, I know that 70% of babies that have a cleft lip are going to have a cleft palate. And if that's a bilateral cleft lip, up to 85% of those babies will have a cleft palate. So I always consult when I'm talking with families, I always prepare them to have a cleft palate in addition to the cleft lip, but hope that they only have a cleft lip. And rarely, like I said, do we detect a cleft palate alone, depending on the study, up to 22%. But sometimes we can suspect it when they've got polyhydramnios or micrognathia. In my 3+ years back here in New Orleans, I've not seen a child prenatally diagnosed with isolated cleft palate by ultrasound alone. I have seen it when we've had kids come in or moms come in for fetal MRI, but again, it's pretty rare to see it on ultrasound alone. And the other things I do in the prenatal consult, so I give the family some anticipatory guidance. I want to make sure that they're following up with a comprehensive craniofacial and cleft team, whether that's me with our team or someone else in the state. There's 4 in the state, 1 in Shreveport, 1 in Baton Rouge, another one here in New Orleans, and then us. Because while I would love to take care of these kids, I want to just make sure that they're getting the best care and finding the family that fits them, or finding the team that fits their family the best. And so if you happen to be practicing somewhere else or you have a family member, you can always go to the American Cleft Palate Association and Team Finder. And there's places across the world that have proven to the American Cleft Palate Association that they have the appropriate people and kind of ancillary services in place. I typically review the statistics and etiology with the family, making sure that the parents understand, especially mom, that there's a good chance that we will never really figure out why your baby's got a cleft. This is 100% not your fault. It's no one's fault. It's many times I use bad luck as a statement, but I always try to make sure that the parents understand that this is not something that was preventable, and it's nothing that they did specifically that caused the cleft. I discussed a birth plan with the family. So before I did my current job, I ran the nursery at Toro for several years. And the big reason I was drawn to this specialty was because of the feeding and nutrition aspect. But it's one thing that I always try to help the families prenatally understand, that just because they've got a cleft lip and palate doesn't mean they have an increased rate of birth-related complications. They have the same rate of C-section, the same rate of vaginal births or needing assistance or APGARs and those sort of things postnatally. It shouldn't change the golden hour of skin to skin or attempting to breastfeed. I've been in the delivery room when a baby comes out and there's something that we didn't expect. And so the first instinct of the delivery team typically is to take the baby away, put them in the warmer, dry them off, look them over, and make sure that they're safe. And that's always the safest option, but especially if we know this baby's going to have a cleft, no one in the room should be surprised when the baby's born, and the baby should go to the breast, should go do skin to skin if the baby's otherwise healthy, pink, mom is healthy and otherwise able to do skin to skin. That's so important. Even though we know this baby's probably not going to be able to breastfeed successfully, it shouldn't change that first hour of bonding and skin to skin for mom and baby. I empower the family to have everything ready at birth. They're probably going to be the most experienced person in the room. They're the person in the room that knows the most about how to take care of a baby with a cleft, typically. And so I try to empower them to know that, tell your birth team, tell them this is going to happen, this is what we want to happen, but have everything ready for them as well. Take the feeding supplies. Make sure we've got a hospital grade pump and we start pumping immediately. Make sure you've got your special bottles. I give the families a special bottle when I meet with them prenatally so that they can take it with them to the hospital and have it. Because most of the hospitals around the state don't have specialized clefting bottles. They may have this one, the Haberman, and I'll talk about it in a minute, but it's terrible. And so I always give them the proper thing to make sure they take that with them. And then I tell the mom, call us as soon as the baby's born, and we'll start working through. I will work with the team at the hospital through the phone. I have taken bottles to hospitals in the region. I have worked with our NICU teams to get some of these bottles placed at some of the hospitals around the region. Most of them are kind of hidden. So I had a baby born a couple weeks ago in Homa, and once they were born, I talked to the NICU team to try to find the bottle that we hid in their NICU. No one was able to find it, but again, there's sometimes we've been tricky in trying to hide some bottles in places so that families can have these when a baby's born with a cleft and we didn't know. So one of the things that I wanted to emphasize today is the importance of a team. So as you see all of these people on the team around this little one closely are the people that are on our team and see the patient most anytime they come to clinic to see the team. And then there's the people that are just right outside the circle that I can always grab within just a few minutes notice and get them to also see the patient. So the team provides a family and patient-centered holistic approach with a unified multidisciplinary plan. Cross-sectional studies have shown that outcomes are improved when you have centralized multidisciplinary cleft care. and when you see a center with a higher patient volume, which makes sense. You want the people taking care of these kids that do it every day. Studies also show that cleft-related outcomes surgically are improved when you're in one of these teams. And those outcomes that they looked at were improved aesthetics, so improved appearance, but also improved speech when they were older, and improved family and patient satisfaction rates when they were older. This reduces the risk of secondary procedures during childhood, adolescence, and beyond, which we'll talk about. So the AAP recommends that children born with cleft lip and palate receive coordinated care through a multidisciplinary cleft or craniofacial team. The difference between a cleft and a craniofacial team is a cleft team doesn't necessarily have to have a neurosurgeon and doesn't have to have a couple other of the specialists, versus a craniofacial team does have to have neurosurgery involvement, as well as some of the other ancillary things. So the first year of life is where I probably spend the most time with families. I want to do a thorough prenatal and family history. I want to do a good, thorough exam, make sure there's no other anomalies going on, make sure their heart sounds great, there's no GU differences, make sure their fingers are all there and there's not extra ones and they're not together. Looking for neonatal teeth, as well as visualizing the palate. I've got a little guy that I suspect of having cleft palate. I want to look, because it's pretty common that, especially if it's an isolated cleft palate, that these little guys in the nursery are just diagnosed as poor feeders or tongue-tied, which I could do a whole lecture on, and however, I'm pretty biased. When it comes to tongue ties, if you've got a little one with a tongue tie, look and make sure that it's actually a tongue tie and not a palatal issue, because about 20% of infants with an isolated cleft palate are not found until after a week of life. It's pretty common for that first baby to not be the best breastfeeder, to have some issues with feeding. And so I feel like a lot of times, especially the first baby of a new mom, we kind of allow a little bit of punky feeding for the first few days to kind of see. But if you've got a little guy, especially that's not feeding well, it's hyperbilly, other things, get your tongue depressor out and take a good look. Gag them, look at their palate, don't just feel of it. Because again, you may not always feel the cleft palate if it's posterior, but gagging them with the tongue blade and looking at their uvula is a surefire way to make sure we're not missing a cleft palate. And then the timing of their first craniofacial team visit varies. Sometimes I will see the babies in the hospital. If they're born at Toro, I go to Toro. If they're born at other places in town or across the state, I'll talk to the families daily while they're in the hospital in the nursery. And typically, even for the first days that they go home, I or my nurse Casey talk to them at least every other day or so. And if there's feeding issues, if there's more concerns, I will see them pretty much the day that they leave the hospital, to come and do an appointment with me. But if there's no issues, they're feeding, growing great, sometimes we'll wait and do their first craniofacial team visit a little bit later. The biggest thing I focus on in this first year is feeding and growth. Infants with an intact palate, so those with an isolated cleft lip or a cleft alveolus, they may be able to breastfeed successfully or use traditional bottles. And I've seen infants be able to breastfeed successfully more than use traditional bottles, because the breast typically is pretty malleable and can kind of go into that cleft and stop airflow through it to improve the baby's ability to form suction, versus a bottle isn't as malleable. And so sometimes they're able to breastfeed successfully, but once we switch to a bottle, they have to use the special bottles. But if you've got an infant with a cleft palate, they're not going to be able to breastfeed effectively. And while I hate it, I'm actually a certified lactation counselor. When I was in the nursery, it's one of the things I got the CLC certification. So I'm 100% pro breastfeeding. But in an infant with a cleft palate, it's just not in the cards. It's not going to work. And I want to make sure that I set up mom and baby to be successful. So I stress this in my prenatal visits and at whenever I see them. I want the baby to get breast milk, but feeding at the breast is not going to not be effective. They can do non-nutritive breastfeeding, so non-nutritive nipple stimulation for bonding between mom and baby, but I don't want the baby spending too much energy, too much time at the breast and spending too many calories there when they're not able to get enough for their efforts. So these little guys are going to need a specialty feeding system. So there's the Hagerman that a lot of the hospitals around the state have. This is what we used when I was a baby, or when kind of through the 90s, even to the early 2000s. And then after that, the better bottles came out. So there's the Dr. Brown's feeding bottle. So it is a typical traditional Dr. Brown bottle that just has this blue valve in it that goes in the nipple. And it allows the baby to not have to form suction to get milk out. Anytime they suckle on the nipple or just close their mouth around the nipple, milk squirts out. The Pigeon is very similar to that. One of the first ones that they did was a Mead Johnson was the squeeze bottle. Basically, you have to squeeze while the baby's feeding for milk to come out. With the valved systems, the baby kind of controls the speed. With the Dr. Brown bottle, the number of the nipple is what controls how much milk comes out each time they suckle, or not suckle because they can't, but kind of close their mouth. With the Hagerman, there's a lot more learning curve to it, with having to make sure that the nipple and the nose line up appropriately and that you squeeze appropriately. So there's a lot bigger learning curve with the Hagerman. It works, but I don't like it. And then cup feeding, which is most common in developing countries, is great because mom can hand express breast milk directly into the cup and then feed it to the baby directly. And there's not a whole lot of parts to the bottle that need to be sterilized. Some of these are even made with special silicone. So when they sit out in the sun for I forget how many hours, it sterilizes it. So those are some options for infants for feeding. Clefting is not a reason to ignore poor weight gain. Yes, infants with cleft lip and palate, when we've looked at data nationally, there's not a study that's been published per se, but when groups of us across the country look at our weights and we compare them to children without clefting, they typically are a standard deviation or two off from their peers and siblings. But these infants should be gaining weight appropriately. They should follow a growth line, even if it's, the first or second percentile. They should still be following a growth curve. And so we do follow weight and feeding very closely in these little guys. It's one way that we partner with our pediatricians in the community, because in these first couple weeks, I want a weekly or sometimes a twice weekly naked weight on a baby scale, on the same scale, and a lot of times partnering with the pediatricians in the community to allow the family to come in and just put them on the scale, not necessarily to have to do a full visit, or for some families do a copay and those things. And always try to partner with my pediatricians and tell them, if you've got a little guy and they come in and their weight's not great, you don't necessarily have to worry about it. Call me and I will take that worry from you. I will work with the family, make sure that there's a good plan, make sure we're feeding appropriately. I can do video visits, or my schedule allows for me to see a patient typically same day or the next day. Kind of whenever they can get to the hospital and see me, I'll be able to see them. Red flags in feeding. This is not just kids with clefting, but in general, coughing, gagging, change in breathing. So they're having to pause and take kind of breaks when they're feeding. Refusing a bottle. You've got little guys that it's not necessarily oral aversion, but if they're not feeding well, they're smart and they know I have to either breathe or feed. And if I'm feeding, I'm not breathing, they're going to pick to breathe and not feed. So sometimes kind of force feeding them is moving in the wrong direction. Some of these little guys, they'll hit a plateau and they can take the 2 ounces that they need, but once they start getting bigger and we need them to take 2.5 or 3 ounces, they just can't for some reason. Or they're taking more than 20-ish minutes to feed. In those first couple days and weeks, we sometimes allow them up to about 30 minutes for a feed. But most of the time we want them taking a feed in about 20 minutes. So when they see me, when they see my feeding therapist, some of the things we do is change the feeding system. So switch the bottles up. We've got a bunch of different bottles, a bunch of different nipples. We've got the pigeon bottle that you can only get with a prescription from Japan. We've got I've got a case of these Dr. Brown bottles and a bunch of nipples in my desk that I will take to any baby that's feeding poorly. We'll sometimes fortify the formula, so we start mixing the formula concentrated. Working with speech therapy, sometimes we'll thicken stuff. And then if none of that works, sometimes I end up having to do supplemental feeding tubes, whether that's through an NG or through a G tube. And typically I jump to a G tube when the infant's having aspiration, when there's unsafe feeding. If they're feeding safely and family's comfortable, I'm comfortable doing an NG at home for a certain amount of time. But that can get really tricky when you've got a baby with a bilateral cleft lip and palate, because their nasal cavity is their oral cavity. So doing an NG is doing an OG, which they pull out pretty easily. So can get kind of tricky. One of the other things we focus on a lot in that first year of life is hearing. So all infants should have hearing screen prior to discharge from the hospital. That doesn't matter if they've got a cleft or not. And the AAP and the early hearing loss detection work group have come up with the 1-3-6 model. So all infants should have screening for hearing loss before a month old. If that testing was not great, they should have a diagnostic test with a pediatric audiologist no later than 3 months of age. And if they do have hearing loss, we should be doing intervention by no later than 6 months of age. So typically when we see children at their craniofacial visits, they see the audiologist every single time. And if there's a question, concern, we recheck their hearing. If they're due for screening, our audiologist will do screening. But we definitely do them before we do it at about 6 months old. And then we do it before any time we know they're going to be sedated, especially if they don't have ear tubes, because doing ear tubes in addition to another sedation that they're doing is pretty easy. And most any of our ENTs will gladly jump in and do a set of ear tubes on our little guys when they've got chronic serous otitis media. And our kids are about 90% or more will have persistent ear effusion in the first year of life. So we talk about doing ear tubes typically when we do their cleft lip repair or their cleft palate repair. And when you do that, whether you do it at 3 months with their lip or 9 to 12 months with their palate, is dependent on ENT preference and sometimes changes based on the team that you're working with. But overall, research shows that these kids have better long-term speech and language outcomes when you do ear tubes versus not doing ear tubes. Another thing that we start doing in the first couple of days of life is pre-surgical molding when we've got a little guy with a cleft lip. Ideally, they can make the cleft smaller over time. They can improve the cosmetic and functional status, meaning it makes the cleft smaller. It makes it easier for the infant to feed. one of the things, the easiest one we do is lip taping. You can see that on the baby doll head there, and the scrunched up little red guy there. It's worn 24 hours a day. It's easy to apply. There's these systems that you see here. Those are called Cleft, and those are, it's about $20 for 7 of those tapes. So for a family, it's about $80 a month to do taping. So our orthodontist has helped us make some homemade taping supplies using orthodontic rubber bands and steri strips that we just give to the family for free. So it may not always look like this. It may look a little different, but sometimes we'll talk about doing taping in these little guys to help with the size of the cleft. Something that's a little newer. It's been around for probably 30 plus years, but the research is just now catching up, is nasal alveolar molding. So it is this little retainer that you see on the bottom there. Typically it starts out as just the retainer that doesn't have those nasal stents. It's typically worn about 24 hours a day, as much as possible. It's made with a specialized orthodontist. So there's only, there's one craniofacial fellowship trained orthodontist in the state, in the region. She does NAM, and then there's another orthodontist here in New Orleans that does NAM. So if you're outside of the New Orleans region, it's not as widely available. It requires weekly to every other week orthodontic visits to look at the fitting of it and to make adjustments. But one of the benefits is, with this, you can also improve nasal shape. So when you've got a unilateral cleft, a lot of times, not only do you have a lip and alveolar difference, you have a nasal difference too, including the nasal ala. So the nostril becomes depressed and the nostril is not as round. And with NAM, we're also able to add these little nasal stents to the front to help round out the nostrils once we get the cleft pretty close to each other. And I say emerging data, the data is not emerging anymore. It's pretty solid, showing that long-term outcomes with NAM are better than taping or non-surgical, like non-pre-surgical molding. That's cosmetic appearance, that's speech outcomes, that's also decreased rates of secondary surgeries in the future. So here is our first little guy. It's actually the one, the little one in pink that I showed you. She was our first patient that did NAM here a couple years ago. And in the first picture, she's just doing taping, and in the second one, she's got her retainer in. So again, it's not always easy, and for all families, it's not always an option, but we'd like to offer that when it's an option. So the first surgery that we typically do in these little guys is the cleft lip repair, and typically it's done between 3 and 6 months of age. Historically, our surgeons used the rule of 10. So they needed to be 10 pounds, they needed to have a hemoglobin of 10, and they needed to, I forget what the other 10s were, but someone developed that in the 50s, and basically the mantra hasn't changed. But now what we typically say is between 3 and 6 months of age, we want them to be growing well. They need to be gaining weight well. They have to have no other pressing medical issues. So if you're not breathing well, if you've got a heart condition, if you've got other stuff going on, your cleft lip repair can wait until we get those other things under control. You can't have an NG tube after a cleft lip repair. So we've got a little guy that we've been using NG tubes for, and it gets time for their cleft lip repair. Sometimes we will coordinate a cleft lip repair with a G-tube placement at the same time. The surgery technique, could be its own lecture, but it's not just sewing the lip together. It is dissecting out each of the dozen of muscles in and around the mouth and reanastomosing each one of those muscles and sewing multiple layers of mucosa in the nasal floor, in the gingiva, and it's a lot more than just sewing the lip together. Like I said, with this surgery, we typically will do ear tubes if needed. They typically have an overnight hospitalization afterwards. That's not only to watch oral intake afterwards, but to make sure their pain is well controlled. Some places have started doing outpatient cleft lip repair, and we may in the future, but for now, we're not. After this, they will still need their specialty feeding system because we did not do anything with their palate. They will still need their regular bottle, their cleft bottle after. And the reason we wait 3 to 6 months is based on facial growth, as well as the risk of anesthesia is less once you're 3 months old. So we do this at about 3 to 6 months to help mold the palate and in theory kind of pull the alveolar segments together and make the palate a little smaller before we get to their cleft palate repair. And there's some emerging data coming out of UCLA showing that it can actually improve weight gain in kids. So at UCLA, they've almost adopted a policy. If they've got a little guy that's not feeding well, not gaining great weight, some of them are actually doing their cleft lip repair a little earlier to kind of help promote weight gain. So that might be something that changes in the coming years, but right now, still the gold standard is 3 to 6-ish months. Sometimes we'll do a 2-stage repair. So we'll do what's called a cleft lip adhesion, and this is typically done between 2 and 4 months of age. This surgery is kind of a bridge to a definitive repair. In this surgery, they don't necessarily dissect all of those muscles out, but they do dissect some of them and put the lip. It is basically just sewing the lip together. And for this surgery, why they do that is if you've got a cleft lip that's really wide, the tension on that for a cleft lip repair can be very high. And so you can end up with higher rates of dehiscence, higher rates of like scar widening, and a poor cosmetic outcome and a poor functional outcome over time. So when we've got a little guy that's got a pretty wide cleft, or sometimes a bilateral cleft, we'll talk about doing a lip adhesion. And then about 3 months later, doing the definitive lip repair, where they come in and kind of sew all of those muscles together. Depending on your surgeon, depending on where they're getting surgery, sometimes they'll come back a week later for a quick sedation to have the sutures removed. Some surgeons do absorbable sutures and some do removable. Right now, our 3 surgeons all do sutures that need to be removed. So they'll come back about a week later for a quick sedation and they go home by lunch. Another thing that we kind of harp on in this age is optimizing dental care before they get teeth. I know it's something that a lot of pediatricians in the community talk a lot about. I'm blessed to have a pediatric dentist with me on my team that gets to kind of harp on this with families, but making sure they're brushing their teeth twice a day, including fluorinated toothpaste from the moment they get teeth. Going to the dentist twice yearly. For our kids with a cleft lip and palate, we do prefer that they see a pediatric dentist just because they're at increased risk of kind of dental differences. And so we do recommend a pediatric dentist for those kids. There's pediatric dentists throughout the state, and I'm sure you know those that are close to you. By a year old or when their first tooth emerges, I talk about limiting juice and sugary beverages, no milk juice in bed, fluorinated water source, or taking a fluorinated supplement is not something that I do a lot of. I need to, and I've started asking some families, but not all families know if their water's fluorinated anyways. And a quick factoid is Baton Rouge is actually one of the largest municipalities in the country that doesn't have fluorinated water. because of the way that their pump system works, and it's multiple systems. And to do that, it would cost an exorbitant amount of money. The other large municipality is Portland, and they voted to take fluorination out of their water because they're hippies. So children with clefting are at increased risk of having natal teeth, absent or missing teeth, sometimes extra teeth, dental crowding, and then deficient enamel. So it's one reason why we harp on it, and I focus on it a whole lot in our kids. Cleft palate repair typically happens between 12 and 14 months of age. Again, we want them to be growing well, gaining weight, no other medical issues. I want them to be sleeping normal. So if this is a little guy that has a history of sleep apnea, we may be doing some sleep studies before, and it's something that I focus on in each one of my visits with them is sleep, and I'll talk about that in a second. Again, they can't have an NG. For the surgery, it's some weird geometry that they drop mucosal flaps and make a Z-plasty. It's magic. I still don't understand it, even though I've had it drawn and seen it multiple times. I just call it magic geometry. Again, they may get ear tubes with this. They stay in the hospital overnight. And the reason we do this surgery at about 9 to 12 months of age is based on historically, when we did the surgery earlier, we saw that these children had smaller maxillas over time and needed further maxillary surgery. In later surgery, these kids had maladaptive speech habits. There are some dietary changes that need to happen before and after surgery for a cleft palate repair. Most surgeons don't let them have a bottle after or a sippy cup, or bottle or pacifier. They need to be switched to a sippy cup or a free-flowing cup. They have to be on a liquid or soft puree, not soft, like a soft puree diet for about 2 weeks post-op. It tends to be a little more painful than a cleft lip repair. We use elbow immobilizers in some kids, sometimes not. The research doesn't necessarily support it, but 80% of surgeons across the country recommend using them. Again, it's anything we can do to help make their palate not break down, we want to try to do. So that's kind of the first year of life. The rest of life, I go a lot quicker. Early childhood, the biggest thing is speech assessment. So making sure they don't have velopharyngeal insufficiency. This is a structural deficit. The palate does not touch the back of the throat, so the air escapes. This can be due to clefting, but we also see it in kids that had a tumor resection in that area. Sometimes we'll see it after they have their adenoids out, or if they just have a short palate or a palate that doesn't work real well. Up to 25% after cleft lip and or cleft palate repair will have VPI. However, it's sometimes tough to really tell if they've got this before 2 years of age because they're not going to cooperate with a speech assessment very well. And getting them to repeat words is not the easiest until they're about 2. But it's also tough for people that aren't trained listening to it to tell, is this nasal air emission? Is this missed learning? Is this articulation errors? Is this apraxia? And that's why I love having a speech therapist on my team to help us figure those little nuances out. So treatment for VPI. There are assessments that look at different, this is kind of a quality of life outcomes and quality of life questionnaire that we can use to see how much their VPI is affecting them. But it's a structural deficit. Surgery or speech therapy may be able to help and get those kids to producing those sounds correctly. But if it's significant nasal air escape, there's not a way that therapy is going to make that resolve. The only way to fix those are by changing the structure, and that's either with a surgery or with a prosthetic, with an obturator, with a special kind of retainer. Again, we do speech therapy in these kids to help prevent missed learning, but typically it alone does not correct VPI completely. I talk a lot about sleep because sleep apnea, our kids are at increased risk of this. Up to 33% of kids, depending on the study, will have sleep apnea. Obstructive sleep apnea can lead to learning issues, behavioral issues, and further health issues. This is due to them having a smaller nasal airway, deviated septum. Sometimes they have smaller pharyngeal airways, and then their palate not functioning correctly. So I get a sleep study probably more than anybody except for the pulmonologist. When I've got a kid with a history of a cleft that's got sleep symptoms as well as learning or behavioral concerns. And if they do have OSA, we talk about treatment. So there's Flonase, intranasal steroids. Sometimes we'll have to do supplemental oxygen, CPAP, BiPAP. And then there's surgical options. But we only want this done with one of the surgeons with our team. Because one of the surgeries is a tonsillectomy or a partial adenoidectomy. And as you can see from that photo, where the adenoids are, if you take that out, it makes it a lot further distance for the palate to have to go to the back of the pharynx to close. And so sometimes we made their speech better, or we made their sleep better, but now their speech is unintelligible. So it's kind of a fine line that we walk in some of these kids between making their speech better and their their sleep worse, and kind of that balancing act. And then in some little guys, we end up needing to do jaw distractions or kind of orthognathic surgeries. Once we get up to school-aged kids, sometimes talking about speech surgery is an option. A lot of times we'll do a further evaluation. We'll do a nasal endoscopic evaluation while they're awake. So our ENT will drive the scope while our speech therapist coaches the kid into saying things. Typically, we also have child life and plastic surgery there, watching to see, is their palate moving? Is it closing appropriately? Is a surgery going to be helpful? Can also do fluoroscopy while speaking. That can sometimes help. And every once in a while, about 1 in 5 kids will recommend doing a speech surgery at some point. Typically only doing this once they're a little bit older, like 4 or 5 plus, because before that age, they're not able to cooperate as much. There's a couple different techniques. Some you can lengthen the palate. You can sew the palate to the back of the throat. Sometimes they'll put a speed bump to the back of the palate to bring the palate closer, or bring the pharynx closer to the palate. And kind of which one we choose depends on what the scope shows. I talk a lot about school performance. So kids with oral facial clefting are statistically do lower, have lower school grades and standardized testing than their age-matched peers. Overall, it's about a 5% difference in composite scores, or about a half a grade level behind. About 8% of kids with clefting are likely to use special education. And so it's something I talk to a lot of my families about, and that's where I lean on my community pediatricians a lot when we're concerned about ADHD or other things. Is it ADHD? Is it sleep? Do we need to talk about their sleep? Do we need to get their speech, their sleep apnea under control so that their ADHD can be under better control? We also do a lot of orthodontics and bone grafting. So orthodontics, typically we start an evaluation around 6 years old. First of all, to expand the palate, get the teeth out of the cleft site, and do a bone graft, typically between 7 to 10 years old. Each surgeon and orthodontic team have their own kind of recommendation of when you should do that. But basically taking hip bone or cadaveric tissue and putting it in the alveolus so that the teeth have a place to live whenever they come in, so that the permanent teeth don't come in, have nowhere to live, and fall out. This also improves the maxillary growth over time. If you do it too early, you can sometimes prevent maxillary growth, but if you do it too late, you can lose a lot of teeth in that area. And this is something that's changed over the past 5 to 10 years, is the age at bone graft has gone down from closer to 10, 11, 12 to 7 or 8. So that's another reason why following with a team pretty regularly is helpful, because getting those things done early. Talking about psychosocial things, making sure that the child doesn't have any concerns about their facial difference, about their speech differences. Our team's pretty adept at asking questions about that without trying to make the child feel self-conscious. As well, I talk a lot about bullying and making sure that there's not bullying going on. And again, following developmental and academic issues pretty closely. My goal in the next 5 to 10 years is to get a camp over the summer for kids with craniofacial differences. So if that's something you're interested in or have a special knack at, let me know, because I'd love to partner up and get something started. But also, again, talking about behavioral issues too in kids and making sure that the family has the support system in place to take care of these issues. And I know I'm over time. I literally only have like 4 more slides because in adolescence, we typically have already gotten a lot of these other things figured out. At this point, we're talking about doing orthognathic surgery. So our kids have a higher risk of having mid-face hypoplasia, leading to upper airway obstruction and malocclusion with the mandible. So some of the surgeries that our surgeons will do is a Lafort osteotomy. So that's a maxillary advancement. It can improve occlusion. It can improve nasal airway. It can also improve nasal tip projection, which you'll see in just a second. But we don't do that until they're done growing. So in girls, that's 15, 16, and guys, that's 17, 18 age. Can also sometimes be coupled with a mandible surgery. Sometimes they'll advance the mandible. They can change the angle and help with the symmetry of the mandible as well. Here's some before pictures of a patient that had a Lafort 1 with a mandible surgery, and you can see not only did his maxillary hypoplasia improve, but his nasal tip projection changed a lot too, and his breathing improved and his occlusion improved. So another patient, she did not have a cleft, but she had significant micronappia, which some of our kids with clefting do. You can see for her, surgeons did a Lafort and a mandible surgery as well as a genioplasty, kind of brought her chin forward. And so it could have life-changing differences from aesthetics, but also functional differences. Here's an example of something a little more. So this guy had a history of a right cleft lip and palate with severe hypoplasia, mid-face hypoplasia. He had a Lafort 2 distraction with this halo type device. We don't use a whole lot of external devices anymore, but rarely it is something that might be used. Again, I've not seen one of these used except for kind of in historic photos. And you can see the difference in this guy 12 months post-op just with his mid-face projection. And then the last surgery we typically talk about after moving the jaw, after doing all those other things, is kind of a completion rhinoplasty. We call it a graduation rhinoplasty and a lip revision. Not only are they improving the symmetry of the nose, but they're doing a septoplasty to line the septum up better on the inside to improve breathing, and as well helping with lip symmetry. And we call it graduation because it's typically the last thing we do as you graduate from the team, and it typically coincides around senior year of high school for most kids. And then the last thing that we talk about upon graduation from the team is genetic counseling. So I always recommend meeting with our geneticist again, because it's been 15 years maybe since they met with the geneticist. And while we thought 15 years ago they were non-syndromic, genetics has advanced astronomically in those 15 years. So maybe it is worth doing some testing now. And then talking about recurrence risk. So an unaffected parent's risk of having a second child with a cleft is about 3 to 5%. An affected parent having a child with a cleft is about 10%. I am the 90% there. My dad had a cleft lip when he was born. I actually didn't even know that until I started doing my fellowship in Seattle, because my dad's had a mustache since he was a senior in high school, so I've never seen my dad's lip. And he'd never thought to tell me this until I was in Seattle doing this specialized fellowship. They're based on if you have certain syndromes or other genetic causes, of course, that can change your risk. But for the 3 to 5 and 10% is for those thought to have non-syndromic isolated clefting lip. And this is something we revisit with the young adults as well as with the family members, and remind them that we're always here in the future too, should they have questions or concerns in the future, because no 18-year-old is ready to have a kid at that point. But in 4, 5, 6 years, they may be, and they don't remember that stuff. So it's stuff that we'll go over again. And these numbers were based on a study out of Denmark. That was a huge study looking at incidences of clefting. So that's kind of the overall timeline. Sorry, I went a few minutes over. I'll take any questions, but on that line, I'm always available. If you ever have a child that you have a concern about, never hesitate to pick up the phone, call me, send me an email, call the office, my nurse Casey, the whole team in the office, and I drop what we're doing when we've got a newborn to get things done. So I want to say thank you to Mary Ellen, who was our nurse coordinator for over 30 years and retired about 2 years ago. And Casey Thibodeau is our new nurse coordinator. She's been in the role about 2 years now, and is doing a phenomenal job. Our plastic surgeons that gave me some pictures, as well as the team in Seattle that kind of helped me with some pictures and kind of all of my knowledge. My last plug is, in the next year, an update to the top recommended reading is going to come out, the Primary Care Pediatrician and Care of Child with Cleft Lip and Palate. And I've been asked to help update that. So in the next year or so, be watching AAP for that, because it'll be coming out.
Awesome. If you have any questions, now's a great time to put them in the chat. I will send those to Dr. Fulton for him to reply to via email, and then send them to you with the post-webinar materials. Let's see, I'm going to switch over to my other board for our final bit of housekeeping. Like I said, we're over time, so I won't take too much time for a Q&A right now. We do need to ask you to go ahead and take our evaluation. This helps us to continue to improve what we are offering for CME, and it's also the place where you need to go to claim your credit. Whether or not you need credit, we ask that you take the evaluation for that improvement aspect. Our next Pediatric Gumbeaux webinar will be January 11th at noon with Julie Emery from the Bureau of Family Health about pediatric care coordination. And then following that, we'll have Michael Johnson talking about physician contracts and how to negotiate your contract to get the best for you. Our next conference is upcoming August 16th through 18th in Alexandria, and that is now open for proposal. So if any of you have an idea of something to talk about at our conference, we would love to hear from you. And you can access more free education from the Louisiana AAP on our YouTube channel. The on-demand education includes our recent webinars on RSV, prevention of stroke in children with sickle cell anemia, identifying medical child abuse, and more. And this webinar will be uploaded as soon as I get around to editing it, which will probably be Monday or Tuesday. I'm going to drop the evaluation into the chat, and then we are good. If anyone has any questions at this time, you are welcome to unmute and ask those.
Dr. Johnson, the teams, the other centers in the state are at Shreveport at the Willis Knighton LSU Ochsner team up there, in Baton Rouge at Our Lady of the Lake, and then here in New Orleans is the children's team and then the Ochsner team. Yeah, and all of them have a Cleft team. Nobody has me, so I didn't really toot my own horn during the recording part, but I'm the only person in the world actually that's done a fellowship in craniofacial pediatrics and does not practice in Seattle. There's been about 4 of us that have done the fellowship, and the other 3 or 4 work at Seattle Children's. So I'm the only one that has formal training in the non-surgical treatment of kids with clefting. So yeah. And again, I always see patients, I see them prenatally, I'll see them whenever, but if a different team kind of is better for a family, I will gladly help a family. Even I've talked to pediatricians before and they call me for certain stuff, and I know I'm never gonna see this patient in person or physically take care of them. While I would love for them to come see me, all I want is the best for the kids in the state. And so I will gladly, even if you know they're following somewhere else, if you have a question or you think something's, a family needs something, let me know, because I also know quite a bit of resources throughout the state for different things as well. So even if they're not my patient, I'll gladly give you some education and offer maybe some resources for the families. Great question. So where can you find the specialty bottles? On the internet through Amazon is the best place to get them. Because typically you can get them, within the 2-ish days. Sadly, you can only buy the kit, which comes with 2 8-ounce bottles, 2 4-ounce newborn bottles, and 6 of the valves. You cannot just buy the valves in and of themselves. Dr. Brown, the company that makes them, says they can't sell them because they're a choking hazard, which is bull, as much as anything else. So this blue thing, that's the gold. That's the important part, because this is just a normal Dr. Brown bottle. This is the important part. As a hospital, we are able to order cases of them along with, whatever from our supplier. So we actually have, and when you order a case of these bottles, it comes with a dozen extra valves. So I have a stash of valves in my office as well. So a lot of times I'll have a family that they already had Dr. Brown bottles because it's what they used for their other kids. They just don't have the valves. And so I can get them valves easily. And as well, sometimes they clog up pretty easily, especially if we start thickening things. And so the valves will kind of break down. So I have extra ones for families because they're also not cheap. So I tend to keep stashes of things to provide to families when needed. And then I know kind of birth hospitals don't. So in the past, Toro used to buy these bottles. They were doing it accidentally. They didn't realize they were buying the Cleft bottles. They were just buying the Dr. Browns, and they threw away all the valves. And then they realized they were spending a lot of extra money on the Dr. Brown's bottles, and so they stopped. And so a lot of places don't carry these and keep these in stock because they just disappeared. People don't realize this is a special bottle and give it away to everybody, and then they disappear. And so that's why a lot of places don't always carry it. Ours, we keep them locked up in speech. There's a hidden spot in our NICU where they're hidden, and then I keep a bunch on my desk in my office.
All right, Dr. Johnson, did you have another question?
No, thanks. That's it. This was awesome. Thank you so much.
Absolutely. Anytime. And like I said, if you ever have a question, concern, never hesitate to reach out, email, call. We're all here just to work together and get these kids in the best situations. So let me know. Wonderful to meet you.
All right. Great to meet you too. Bye, Julie.
Bye.
Bye. Thank you, Dr. Fulton.
All right.